Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Dr. Irfan. I am a final year medical student. I'm here to present my presentation on the physical examination of central nervous system, and my patient is Dr. Ayaz. And here we start. These are the group members. So let's start our discussion on general physical examination. First of all, in every systemic examination, we have to measure some general vitals like pulse and blood pressure, jugular venous pressure, fever, pallor. We will check these, and these things will disturb in some neurological conditions like decreased pulse rate, in Cushing reflex, any condition which lead to increased intracranial pressure, and resting tachycardia, and atrial fibrillation and feeble pulse, carotid pulse in atherosclerosis, and blood pressure may increase, decrease in any neurological condition like increased blood pressure in intracranial pressures. Cushing reflex, orthostatic hypotension means when we suddenly get up from sitting or lying position, so pulling up the blood lead to hypotension, and jugular venous pressure, increase in outpatient output states, and fever we can see in meningitis, which is the inflammation of left meninges, and encephalitis, brain abscess, epidural abscess, and pallor in some conditions like vitamin B12 deficiency, which can also involve the demyelination of the nervous system, and icterus in hepatic encephalopathy or icterus. These are the general things we see in neurological examination. So first of all, these our approach according to inspection, then palpation. First of all, we will see the patient skin, because some of the conditions, some of the skin lesion also related to the central nervous system disease. That's why I included some problems. These are the neurocutaneous syndromes characterized by the abnormality of the both the integumentary and the central nervous system. And most important are the neurofibromatosis 1 and 2. So what is neurofibromatosis means? There is involvement of the nerves, peripheral nerves, and also involvement of the skin. So in neurofibromatosis type 1, there is also formation of neurofibroma and also involvement of the skin nodules, caphaloid spots, and neurofibromatosis 2. There is involvement of the bilateral vestibular schwannoma, multiple meningioma. And the second condition is tuberous sclerosis, which involves the epilepsy, low intelligence, adenoma, sebum, and Stolz-Weber syndrome. There is involvement of the skin, which show the portman spine and unilateral facial nerves. And after studying these neurocutaneous syndromes, as our patient Ayaz, we inspect his skin. So there is no presence of a skin lesion, so it's normal. Then our next step is palpation. So how can we palpate central nervous system? The main important thing, we palpate peripheral nerves, because there is some disease which involve the nerves, which can lead to the thickening of those nerves. So what are those nerves? So detecting the enlargement of the accessible nerves is very helpful in assessing the patient with peripheral nerves disorders, as only a few types of neuropathy lead to the nerve thickening. So these are the causes of nerve thickening. Most importantly is infective, which is leprosy, and these other like tumors, nerve infiltration like acromegaly and amyloidosis, hereditary. But most important thing, what are the nerves and what are the most common sites involved in nerve thickening? Because we are talking about physical examination, so and palpation. So sites of the palpable nerves: supraorbital, cervical, greater auricular, median, ulnar, radial, and common peroneal or posterior tibial. These are the common sites which involved in the nerve thickening. So In these pictures, we can clearly see the physical examination and the palpation of the peripheral nerves. Supraorbital nerves we can see because the supraorbital nerves supply this area. So we can easily palpate if there is any thickening of the supraorbital nerve. And also greater auricular nerve, because greater auricular nerve crosses this sternocleidomastoid muscle. So we can easily palpate after stretching this sternocleidomastoid muscle. And the next is greater auricular nerve of neck. After moving the head to one side, when the sternocleidomastoid muscle stretch, we can easily palpate. Next one is ulnar nerve. Ulnar nerve is most prominent at the medial epicondyle. So medial epicondyle is of the elbow. This is the important site where we can palpate. And then common peroneal. Common peroneal nerve we can palpate behind the fibula, neck of fibula. So uh, uh, close करना. So let's, after palpation of the nerves, peripheral nerves, now we will talk about other things. Now we will talk about the higher mental functions. What is higher mental function? Means those functions which can control whole body. Most importantly, these are the handedness. Means we have to check the patient is right-handed or left-handed. Why it's important? Because after any trauma, any stroke to the patient, any cardiovascular accident to the brain, so it's important to further rehabilitation of the patient. And for the because for rehabilitation means they can easily, after recovering from that condition, they can easily perform those activities. That's why handiness is important. So for this, we can ask the patient to kick a football because we have to check it's right-handed or left-handed, and also we have to ask the patient to fold the arm and in front of the doctor, if because if he is right-handed, he fold the his hand and the right hand is interiorly present. So and then we will check appearance and behavior, mood and effect, thoughts and perception of the patients. And then orientation, about orientation we ask about time, year, season, place, and the person, what is your name, how old are you, where are you from, and what is the name of your wife, brother and father. And memory is important because we can ask about immediate memory like digit span. We can ask the patient like count 235 and 532. So these we can repeat these words for immediate memory. But and also there is recent memory, short memory. So we can give the patient some pens, 2 3 pen, and we can take after 5 minutes. We can ask about those pens. So if he know about those pens, so means it's a short memory is intact. If we don't know, means it's short memory is not intact. And about remote means long memory. Patient found of information reflect their remote memory. We can ask about school detail, birthday details, and also about the major events, history of the patient. And consciousness means we preferable to describe the patient's state of responsiveness or use objective well-defined scheme like Glasgow Coma scale, because this scale we can use any traumatic patient when they unconscious and they enter the ICU, so we can check according to this Glasgow Coma scale. And maximum score is 15 and the minimum is 3. And coma is equal to if the Glasgow Coma scale is 8 or less than 8. So these are the important things. We can check eye opening, verbal response, and motor response. Then we will check the speech because there is some speech problem. If there is problem in their mental function, so we can how to ask listen to the patient, spontaneous speech, volume, rhythm, clarity. Ask the patient to repeat such words like yellow lorry and some sentences. Ask the patient to count stability to 30 seconds to assess the fatigue. Because why to we have to assess the fatigability when we speak, because there is a disease which is the myasthenia gravis. When we speak for a longer time, which can lead to fatigability, that's why we have to check and ask the patient to cough and stay off. Observe the soft pallor rising bilaterally, and dysphagia means these are the conditions when we cannot comprehend and speak properly. So because they in our brain there are different areas, area 22 which is called the Wernicke area, so which can lead to the comprehension, and Broca area, fluency, which is responsible for the spontaneous speech output and the fluency. So if there is any disturbance in these areas, which can lead to the dysphasias. During spontaneous speech, listen to the fluency, appropriateness of the content, and show the patient a common object like coin, pen, ask its name. If it continue means it's these speech areas are intact, and ask the patient to read a passage from newspaper, ask the patient to write a sentence, examine his handwriting. So if there is any receptive aphasias, so which is due to Wernicke aphasia, Wernicke area is problematic, and if non-affluent expressive aphasia due to Broca aphasia. So these are the conditions, these are the things we can check in high mental functions. So next thing is important, we can see in the cranial nerves. First of all, olfactory nerve. Olfactory nerve, as you know, is related to the smell. So what is the method of examination of olfactory nerve? First, we have to check the patient nostril. Is there any local blockage? Is it open? So then we have to ask the patient, put your one finger on your nostril one, and then we smell some perfume, some other thing, some chemical, so he can smell. And there are some conditions which can lead to the anosmia. Anosmia means there is loss of the smell, and local cause like acute rhinitis, systemic like Parkinsonism, meningitis, head trauma, syndromes like Foster Kennedy syndrome, and impaired smell, bacillus meningitis, chorea, Huntington disease. And other second cranial nerve is the optic nerve. In optic nerve, we have to check visual acuity, visual field, color vision, fundus examination. So how can we check visual acuity? First of all, there are two methods. Snellen charts for near vision. We have to ask the patient to So we have to ask the patient to read the sentence, read these words from Snellen charts and Jaeger charts for near vision, and also visual field testing because there is any disturbance in the tracks in the pathway of the vision, so we can use visual field testing. And color vision, we use Isara charts and for color blindness. Fundus. So here we discuss about the optic nerve, which is the cranial nerve too. So what is the important thing about it is related to vision, and we have to do the fundus examination. Fundus examination, the instruments which we can use is the direct ophthalmoscope. So why fundus examination is important? You know? Because some of the disease can affect the fundal area and cranial nerve, because it's a cranial nerve too, it's a part of brain. Any condition which can lead to intracranial pressure, high intracranial pressure affect the optic nerve too. So which, if there is any condition which can lead to high intracranial pressure, can cause papilledema, means there is optic nerve head which can cause the blurring and swelling of the optic head, and that's why we have to do the fundoscopic examination. And fundoscopic examination is also important for some systemic disease which can affect the fundus area, like we can check in systemic hypertension and also in diabetic retinopathy. So that's why this fundoscopic examination of eye is important. Then we will discuss about the cranial nerve 3, 4 and 6, which oculomotor, trochlear and abducens. So why this is important? Because these nerves are related to the movement of eye and the movement of upper lid. So first thing we will approach like this, we approach to the upper lid. So the eyelid, what is the main problem in the eyelid ptosis? What is ptosis? Narrowing of the palpebral fissure due to inability to open an upper eyelid is called ptosis. There are multiple conditions, maybe congenital and acquired. Acquired may be neurogenic, in as in Horner syndromes. In Horner syndrome, there is sympathetic chain blockage, which can lead to anhidrosis, miosis, and thunder palsy, neuromuscular disorders like myasthenia gravis, which can lead to the ptosis, and also mechanical ptosis due to eyelid edema. As you can see, this patient is suffering from the upper eyelid edema. So there is mechanical ptosis, and this patient is neurogenic ptosis. And also we can see reversible ptosis. What is reversible ptosis means? If there is a condition, if we do some kind of test, so there will be reverse of that condition. So most commonly reversible ptosis seen in myasthenia gravis. What is myasthenia gravis? Myasthenia gravis is autoimmune disease in which the autoantibodies are formed against the acetylcholine receptors. Postsynaptic channels neuron, there is acetylcholine receptors, so those antibodies destroy those receptors, and so there is like no proper stimulation and less acetylcholine, and for this reversible ptosis we use ice pack test. What is ice pack test? We have to take some ice bags and put on the ice, because due to coldness, so these coldness can reverse the acetylcholine esterase activity, and which can lead to accumulation of the acetylcholine in the synaptic cleft, so that can reverse the condition. So this is the important thing, because reversible ptosis most commonly seen in myasthenia gravis, and we can use ice pack test. Then ocular movement testing. Ocular movement testing in a patient with right ophthalmoplegia. So as you all of you know, this is the patient with the abnormality in their in her eye. So all of you, please concentrate on this condition, and can you tell me which eye and which nerve is involved? So as you know, we can see there is stasis of this eye, means right eye is stasis at one place, and left eye can move in all direction. So right eye is laterally abduction, so means there is no movement toward the medial side. So there is medial rectus involvement, medial rectus muscle involvement. So which nerve supply the medial rectus? Oculomotor nerve. So that's why there is most commonly palsy of oculomotor nerve, as you know. So in this table we can see there is right third nerve palsy, and there are right fourth nerve palsy, and right sixth nerve palsy. So this is the condition we can see in this picture. So this patient is a patient with third nerve palsy. Next, cranial nerve 5 is a trigeminal nerve. It's a pure sensory nerve, and the sensory and motor nerve. So that's the testing of the sensory component, examination of sensory component of trigeminal nerve. We have to touch the patient's face, because there is three division of the trigeminal nerve: ophthalmic, maxillary, and the mandibular. So examination of ophthalmic division of trigeminal nerve, we have to touch the head of the patient, and then maxillary division we touch the face area, and for the mandibular division of trigeminal nerve we have to touch the mandibular area of the patient. Next is the testing of the motor component, because the maxillary division supplies the masseter muscles, so we have to check the motor component. We just put our hand on the face, and we have to ask the patient just move his jaw, so we can check the motor component of the patient. And examination of motor component of trigeminal pterygoid muscle we can check like this. And next is the jaw jerk or mandibular reflex. So what is this mandibular reflex? First of all, we have to ask the patient, like this is our patient Abubaker. So in this condition, we will ask the patient, our Abubaker, like open his mouth little open. So like I put my finger like this, and I will, so this is our hammer. So if I push like this, so when he move his jaw downward and then suddenly upward, this is called jaw reflex. So we can see in cranial nerve 5 jaw jerk or mandibular reflexes. Then demonstration of the corneal conjunctival reflex. As we know that ophthalmic division of trigeminal nerve supplies the cornea, so we can check the corneal reflex by just checking by touching the cornea of the patient. Then facial nerve. Facial nerve is important because it supplies the face, and the facial muscles are the facial expression, and also supplies the anterior two-third of the tongue. So examination of the frontal belly of the occipital, because so we check the forehead of the patient. Examination of orbicularis oculi. We ask the patient. We put his finger here and open the his eyes forcefully, and ask the patient to close eye forcefully. So an examination levator, anguli oris, and the examination of progenitors and platysma. And examination of sensory, because sensory supply of the seventh facial nerve is the anterior two-third of the tongue. So we protrude the patient tongue, and we put some salt and some sweets. So we ask the patient to taste this. And the next one is the cranial nerve 8, which is the vestibulocochlear nerve. So there are two components. Cochlear component we can examine through the Rene and Weber test. Rene test means we take tuning fork and we place at the mastoid process, and so the patient can sense the vibration of that tuning fork. And also Weber test placement of the tuning fork in the midline of the vertex. Like here we put the tuning fork in the Weber test. So this is the interpretation. If their bone conduction, BC means bone conduction is more than air conduction, means there is Rene test negative. If the air conduction is more than the bone conduction, then Rene test is positive. So vestibular component we can check by doing the chloride test. Chloride test is just a simple test. In this condition, in this test we just put cold and hot water. If we put hot water in the air, then the movement of the ice in the same direction of the air where we put the hot water. But if we put cold water, then the movement of the ice to against the opposite toward the that air. So this is the chloride test. Then closopharyngeal nerve. So